Hello dear students, welcome to the class on anti-migraine drugs. In today's session, let us understand the drugs which are useful in the treatment of migraine. So we'll also go through the treatment available for acute attack of migraine as well as the preventive measures which are available to avoid the migraine attacks. To understand the migraine pharmacology and the drugs which are used in the treatment as well as prophylaxis of migraine, one has to understand the serotonin neurotransmitter and their activities. So myself, Dr. Padmanabha, PS, your pharmacology faculty. So coming to the overview, this session will be taken under these headings. So let us understand what is serotonin synthesis, serotonin receptors which are available, and serotonin related drugs. Once we understood this serotonin synthesis, receptors and related drugs, the next move on to the migraine. So let us understand what is migraine, what is the basic pathology which is involved behind the migraine, which are all the drugs which are used to treat migraine, and are there any drugs which are available to treat the acute attack of the migraine, and are there any drugs which are available for the prophylaxis of the migraine, and what are the newer drugs which are there in the current practices, and let us do the summary. First, coming to the serotonin synthesis. So serotonin is a neurotransmitter which is present in the central nervous system, So what is the function of the serotonin basically? Serotonin helps in the regulation of the mood and the behavior. So how this serotonin is synthesized in our body? So to synthesize the serotonin, it requires a amine called as tryptophan. So tryptophan will be converted into 5-hydroxytryptophan with the help of tryptophan hydroxylase, and from from 5-hydroxytryptophan it will be converted into 5-hydroxytryptamine, which is 5-HT, with the help of tryptophan decarboxylase. So serotonin will be synthesized with the help of the tryptophan, which is a amino acid. So once this 5-HT is synthesized, as we said, it helps in regulation of the mood and the behavior, and this serotonin will going to act on different or various receptors which is spread across the body. So they can act on 7 receptors. So serotonin receptors can be classified as 5-HT1, 5-HT2, 5-HT3, 5-HT4, 5-HT5, 5-HT6 and 5-HT7. So in this session, let us concentrate mainly on important receptor which are required for the treatment of the migraine and other conditions. So coming to the serotonin receptors and related drugs, as we discussed, the 5-HT1 receptors are predominantly found in the smooth muscles of the blood vessels. So in the blood vessels, 5-HT1 will be located. So where do the 5-HT2 will be located? 5-HT2 will be located in the smooth muscles. They will be located in the cardiovascular system as well as in the platelet. So activation of 5-HT1 will lead to vasoconstriction. Activation of 5-HT2 receptors will lead to contraction of the vascular smooth muscles in the heart, as well as it leads to platelet aggregation. Apart from that, most of these 5-HT1 to 5-HT7, they are located in the CNS. And these receptors, all the receptors are mediated through G protein coupled receptors, except for 5-HT3, which is mediated through ligand gated ion channels. So coming to the very important agonist and antagonist, where they are used. So coming to the serotonergic receptor agonist, we have 5-HT1A agonist. We have a buspirone, which is used in the treatment of anxiety as an anti-anxiety medication. Coming to the 5-HT1B, 1D agonist, they are present basically in the smooth muscles of the blood vessels. And we have a drug sumatriptan, which is a 5-HT1B, 1D agonist, which are used in the treatment of the migraine. The next we have a 5-HT4 partial agonist. We have a drugs like tegaserod, cisapride, rinzapride, and mosapride, which are useful in the treatment of the gastroesophageal reflex disorders. And next we have a drug from the antagonistic group of drug, which is going to antagonize the serotonin receptors. So under this we have 5-HT2A, uh, 5-HT2A, 2C agonist, antagonist. So basically we have drugs like ketanserin, ritanserin, clozapine, risperidone, ciproheptidine, and methysergide. So ketanserin is used as antihypertensive medication. Clozapine, as you know, they are the classical atypical antipsychotics. Ciproheptidine will going to increase the appetite levels, which can promote the weight gain, and methysergide are also used as a prophylactic therapy in the treatment of migraine. So sometimes these antagonists can also act as a agonist also, because they do not have that selectivity. And coming to the 5-HT3 antagonist, under 5-HT3 antagonist, we have ondansetron, granisetron, palonosetron, etc., which are very useful in the treatment of the chemotherapy-induced nausea and vomiting, as well as post-operative nausea and vomiting. The concern with respect to the methysergide, you should remember at this point of time, is it causes a side effects such as pulmonary fibrosis, endocardial fibrosis, and retroperitoneal fibrosis. So having seen this serotonin receptors and the related drugs, let's move on to the migraine. So what do you understand by migraine? So migraine is a unilateral pulsatile headache. So it is a unilateral pulsatile headache which occurs. It occurs in females more when compared to the males. The incidence as well as prevalence of migraine is more in case of females when compared to the males. So usually they presents with the unilateral pulsatile headache, and the reason for the headache is due to the dilation and inflammation of the affected cerebral vessels. So cerebral blood vessels will be dilated. Once the blood vessels in the cerebral gets dilated, what happens is, surrounding the blood vessel there are stretch receptor or nerve fibers which are connected to the blood vessels. The stretching of the nerve fibers or the nerve endings which are surrounding the blood vessels will going to mediate the impulses, will going to carry the impulses that will going to spread across the brain, which will be felt as the pain in the head. So the classical presentation will be unilateral pulsatile headache. And the recently the common pathogenesis which is behind the migraine is the CGRP, that is calcitonin gene related peptide. The most culprit or pathological abnormality which affects the migraine will be your CGRP, that is calcitonin gene related peptide, which is a principal mediator for the neurogenic inflammation of migraine as well as vasodilation seen in the migraine. So calcitonin gene related peptide are involved in the neurogenic inflammation as well as the vasodilation, which will going to cause the migraine. So what will be the target? You need to target is to reduce the inflammation. Second target is to reduce the vasodilation. So you need to decrease the inflammatory activity as well as you need to decrease the vasodilating capability. So that to achieve, you need to give a vasoconstrictor, and also you need to decrease the inflammatory activity. So next, coming to the drugs which are useful in the treatment of the migraine. So basically, as a important drug which is used in the treatment of migraine is very simple drug is your non-steroidal anti-inflammatory drugs that is the analgesics. So under analgesics, we are going to use a simple non-steroidal anti-inflammatory drugs like paracetamol, you can use ibuprofen, you can use aspirin, etc. Apart from that, you can also use the serotonin related drugs, that is 5-HT agents. 5-HT agents like sumatriptan, ergotamine, etc. And also the newer group of drugs which are there in pipeline is CGRP blockers. CGRP blockers. So sorry for the typing error. That is CGRP blockers. CGRP blockers. That is calcitonin gene related peptide blockers. So basically the CGRP, what is the effect of CGRP on the blood vessels? CGRP will going to cause vasodilation. So here you need to give a blockers or antagonist of CGRP so that vasodilation will not occur. So based on the severity of the migraine, it can be classified into mild migraine, moderate migraine, and it can be classified into severe migraine. So to treat the mild migraine, the analgesic NSAIDs will be sufficient. If the patient is not able to recover from the non-steroidal anti-inflammatory drugs, you can add with the one more group of stronger NSAIDs. You can start with the basic paracetamol. If it is not relieved, you can go with the higher NSAIDs like ibuprofen, aspirin, etc. And since migraine can be classified based on their the symptoms, it can be classified into two types. One is the classical migraine with aura and common migraine without aura. So what do you understand by aura? Aura means there will be presided symptoms like nausea, vomiting, etc. There can be giddiness, there can be vomiting sensation, etc. There can be of symptoms related to visual sensory system, etc., visual, motor, etc. So basically all these symptoms will going to tell the patient will going to have migraine. So appearance of those aura related findings will help in the individual for recognizing that they are going to have a migraine attack. So classical migraine will present with the aura symptoms and common migraine will have without aura symptoms. So usually based on severity, you can go with the NSAIDs, higher order NSAIDs, and also since they are associated with nausea and vomiting, you can add on with the drugs like antiemetic drugs, antihistaminics, etc. And in case of severe type of migraine, you need to go for drugs like the ergot alkaloids, the hydroergotamine, or you can go with the triptans for termination of the acute severe migraine. So next, moving on to the individual drugs, let's discuss about the ergot alkaloids. Under this, we have got very two important drugs, that is ergotamine, which is given orally as well as sublingually, and we have an dihydroergotamine, dihydroergotamine, which is given parenterally. And these two drugs basically they block the 5-HT receptors. They are the partial agonist and antagonist at 5-HT1 receptors. So the basic mechanism of ergotamine is they behaves as a partial agonist as well as antagonist at 5-HT1 receptors. So usually on the blood vessels, what it causes is it causes vasoconstriction. Vasoconstriction. The partial agonist will going to cause the vasoconstriction, and what will happen is there are agonists which are located on the presynaptic nerve terminals which have the 5-HT1 receptors. Activation of 5-HT1 receptors will going to decrease the release of the serotonin as well as other mediators which can increase the size of the blood vessels, which will going to cause the vasodilation, and that will going to increase the risk of migraine attacks. Basically this ergotamine, what is the effect of ergotamine on the blood vessels? They are going to cause vasoconstriction. So basically they are used to abort the acute attack of migraine, and these drugs can be added with the caffeine. So what is the advantage of adding caffeine? So caffeine will going to enhance the absorption of the ergotamine. As we know that it is a powerful vasoconstrictor, this effect will going to add on to the effect of the vasoconstrictor effect of the ergot alkaloids. So that is the reason why these two are combined with each other in the treatment of migraine. And one of the side effects that you're going to encounter with ergot alkaloids frequently is nausea and vomiting during the migraine attack. This will become a drawback for the use of the ergotamines. So coming to the triptans. So under triptans, you need to remember a very classical drug, that is sumatriptan, which can be given subcutaneously in the treatment of the acute attack of migraine. So what is the mechanism of action of the sumatriptan? Sumatriptan is a selective agonist at 5-HT1B1D receptors. So it is selective agonist at 5-HT1B1D receptors, which are present on the blood vessels. Thereby it causes vasoconstriction. Thereby the headache which was occurring due to vasodilation will not occur, because these drugs will going to vasoconstrict the cranial blood vessels. So it mediates its action through three different mechanisms or three different ways. One is through the vasoconstriction, thereby it vasoconstriction of the extracranial blood vessels, that is cerebral blood vessels, and also it suppresses the inflammation which are released around the blood vessels due to the exudates which may go outside the blood vessels, and those exudate can irritate the nerve terminals which are surrounding the blood vessels. And also the third mechanism is it will going to block the trigeminal nerve transmission. And one of the advantage of triptans over the ergot alkaloids is triptans will going to suppress the nausea and vomiting during the attacks of migraine. So it is a drug of choice. So triptans are the drug of choice for aborting the acute attack of migraine. Acute attack of migraine or the preferred drugs for the acute attack of migraine. So which is the most common drug which is used in the treatment of migraine? So most common drug will be your non-steroidal anti-inflammatory agents like ibuprofen, paracetamol, etc. But to about the acute attack, the drug of choice or preferred drug will be your triptans. If they ask about most commonly drug, your answer should be your non-steroidal anti-inflammatory drugs. The only disadvantage of these drugs is they're short acting and they have got low oral bioavailability. Which is the longest acting triptans? We have provatriptan. The fastest acting congener will be of rizatriptan. And what are the other triptans which are available? We have zolmitriptan, elytriptan, naratriptan, and almotriptan. And these are available in different combination. This can be given as a intranasal route, oral, subcutaneous, etc. So only disadvantage or the contraindication which you need to remember is, since it causes vasoconstriction, it can cause coronary vasospasm, and therefore they are contraindicated in patients who are having ischemic heart disease. And apart from that, they are also contraindicated in case of hypertension, as it can aggravate the blood pressure. They are also contraindicated in epilepsy, pregnancy, liver, as well as renal impairment. And also please remember that within 24 hours, the triptans as well as ergotamine should not be administered within a 24-hour each, within the 24-hour duration, because each of these drug will going to aggravate the blood pressure. And apart from that, coming to the different differences between with respect to the maximum activity and minimal activity carried by the triptans with respect to the oral bioavailability, naratriptan has got the maximum oral bioavailability compared to sumatriptan. Duration of action longest with the provatriptan, shortest with sumatriptan. Onset of action is fastest with the rizatriptan and the slowest with the provatriptan. So provatriptan is slowest, but it acts for a longer duration of time. So plasma protein binding, we have a maximum with elytriptan and lowest with the sumatriptan. And potency wise, highest potency with seen with naratriptan and minimal with the sumatriptan. And next we have a whenever a triptan and the ergot are contraindicated, especially the patient has got any cardiovascular conditions, In such patient, you can go with the opioids like intranasal butorphanol for the treatment of acute severe migraine. If it is not relieved, you can go with droperidol, and if it is not relieving the droperidol, you can go with the propofol, that is general anesthetic agents. So next, coming to the prophylaxis of migraine. For the prophylaxis of migraine, you understand if the attacks are very frequent, if the attacks are more than 2 to 3 per month, then the individual would require a prophylactic therapy to prevent the acute attacks. The most common prophylactic drug will be a non-selective beta blocker, that is propranolol. And we have a monoclonal antibodies against the CGRP receptors. Then we have a calcium channel blockers like flunarizine, diltiazem, verapamil, nimodipine. We have methasergide, cyproheptadine, and tricyclic antidepressant like amitriptyline, imipramine, and nortriptyline. We have a clonidine, which is alpha 2 agonist, centrally acting alpha 2 agonist. We have a topiramate, which is anti-convulsant, and also we can use valproate and gabapentin. And newly added drug, that is monobotulinum toxin A, which is a very new drug in the treatment of migraine. And also we have a candicertan, again a newer inclusion into the prophylactic therapy. So usually you can use other drugs from the beta blockers such as timolol, atenolol, metoprolol, and nadolol, but one should be careful that these beta blockers should not be given in a patient if the patient has got bronchial asthma or COPD, because being a non-selective beta blockers, it will going to cause bronchoconstriction and it will going to worsen the bronchial asthma symptom. The patient may die also. And also you should be careful that the drugs with the intrinsic sympathomimetic activity will be ineffective in controlling the migraine attacks like the pendolol. Next, we have a monoclonal antibody. This will be discussed in the upcoming slides. And calcium channel blocker has got additional action that it blocks the sodium channel, thereby it will going to decrease the triggering of impulse generation, which can lead to vasodilation. We have a diltiazem, verapamil, nimodipine, etc. And we have a topiramate, that is anticonvulsant drugs. And onobotulinum toxin A is a newer inclusion. So whenever there is a headache occurring for more than 14 days per month, there can be administration of multiple injection, 12 week apart, multiple injection around the head and neck to try to dull the future headache symptoms. And also the candicertan, which is a ARB, that is angiotensin receptor blockers. Coming to the newer approved drugs, we have a lesmediton, which is a 5-HT1F agonist, which will going to reduce the trigeminal nerve stimulation, induced plasma and plasma protein extravasation in the dural vessels, which is an underlying pathology for migraine pain. They are useful in the termination of acute attack of migraine. They are used orally. And one of the advantage over triptan is it lacks the vasoconstrictor action, which can be used in cardiovascular patients. So better, it has got better cardiovascular stability. So coming to the one more group of drug, that is anti-CGRP agent, that is CGRP, as you know that they are the powerful vasodilator peptide neurotransmitter which are responsible for migraine headache. So it also, this CGRP will be released from trigeminal nerve fibers as well. Whenever there is a migraine headache, this CGRP will be released. And we have a monoclonal antibody which will going to bind to this CGRP peptide and they prevent the binding of CGRP onto the CGRP receptors. So we have a eronumab which binds to the CGRP receptor, which prevents the activation by the peptide. We have a premanizumab, we have a galcanizumab which binds to the CGRP and prevents it binding to the receptors. So these are administered through subcutaneous route and they are got slowest onset of action and their duration of action will stay up to 1 month. And they're mainly used for prophylactic purpose to prevent the attack of migraine. For the prevention purpose, we are using this monoclonal antibodies. Next, we have a ubrigipant, which mainly blocks the CGRP receptor because of their oral small molecules. So next, we have a CGRP receptor antagonist, that is ubrogipant as well as rimagipant. which are used for termination of the acute attack of the migraine, which needs to be given through oral route. And as we discussed, we have got CGRP antibodies, which binds the peptide itself, like fremanezumab, galcanezumab, and terranumab. So one more drug for prophylaxis is onabotulinum toxin A, which is approved to prevent the headaches, especially in adults who are having chronic migraine. And you need to administer 12 weeks as a apart multiple injection to decrease the pain. Coming to the summary, in this class we have discussed about the serotonin synthesis, serotonin receptors. So serotonin synthesis takes place by the tryptophan, and serotonin receptors, we have 7 receptors, and all are mediated through G protein coupled receptor except for the 5-HT3, which is the ligand gated ion mediated actions. Serotonin related drugs we have dealt mainly, you need to concentrate on sumatriptan, which is a preferred drug in the treatment of the acute attack of migraine. So migraine, we have learned about migraine types, severity of migraine, how to divide the migraine based on severity, and we have also learned about the pathological abnormality behind migraine. Basically, it is related to CGRP. CGRP is a culprit. So drugs which are available for acute attack, mainly the NSAIDs, most commonly used, most preferred will be your serotonin. Next, we have a ergotamine. All this ergotamine and serotonin should be avoided in patients who are having cardiovascular abnormalities or cardiovascular conditions, because it will going to cause vasoconstriction, which further can lead to coronary vasospasm. Why we need to add a caffeine along with the ergotamine? Caffeine will going to increase the absorption of the ergotamine, as well as the caffeine will has got a powerful vasoconstrictor activity. And prophylaxis of migraine, the most commonly used is the propranolol, which is a non-selective beta blocker, and propranolol should be contraindicated if a patient has got migraine along with the bronchial asthma. In such case, you need to go with the other prophylactic drugs like the topiramate, calcium channel blockers. We have CGRP, this receptor antagonist, CGRP, monoclonal antibodies, CGRP receptor antagonist. We have onabotulinum toxin A, we have lasmiditan, etc. We have clonidine, we have tricyclic antidepressant, we have cyproheptadine, etc. So this was about the serotonin neurotransmitter importance with respect to the migraine, and we also discussed about the treatment for the migraine, acute treatment available for acute attack of migraine, and the treatment available for prophylactic therapy or prophylaxis of migraine, and newer drugs which are available for the treatment as well as for prevention of the migraine. Thank you.